We will finish the session with a talk about the analysis of prosodic patterns in conversational speech in people with Alzheimer disease. The speaker is Cenk, Demiroglu. Sorry. Okay. Hi. So I'm going to talk about some of the preliminary studies we do at University about prosodic patterns in Alzheimer's disease. We are actually at this stage, we are collecting data and doing some preliminary studies on the data, extracting some speech-related features and trying to see if these features have any discriminatory power to distinguish between healthy people and ill people. First of all, probably most of you don't know about us. I'm from Prosodic University, and it's a private school in Istanbul, Turkey. So it's one of the best private schools in terms of faculty profiles in Istanbul. And I founded the speech lab about 2 years ago. Before then, I was in the US for about 10 years, and then came back home and started the lab. We are tightly connected to industry. The school is tightly connected to industry. Okay, our mission is to do work with industry, and not just in Turkey, but also in Europe and with US. And we have tight relations with AT&T Research. Our speech group is tightly connected to them. And we have a spin-off company, Neosys. So, and we are trying to commercialize our research through this company. Our primary focus is on developing speech technologies such as speech recognition, synthesis, and speaker verification. We have state-of-the-art systems, world-class systems. And we are also focused on machine learning theory. Nowadays, speech people are moving in the direction of machine learning. So we are applying some of the advanced techniques in machine learning to the speech field. That's where our interest comes from, the machine learning. So why are we into biomedical? Well, there are several reasons for it. Health applications of speech is an emerging area in the speech signal processing field. That's why we are trying to get into it. It's an open area, it's a very promising area in terms of research. Right now we are involved in 2 research areas. One of them is Alzheimer's diagnosis. The other one is depression diagnosis and monitoring. So we want patients to go to doctor, and then doctor diagnoses these patients, and then when the patient goes home, he can call our automated system. We have a little call center system. It's cheap. The patient can call every day, and we can monitor the progression of the disease, and give feedback to the doctor and give reports to the doctor. Also in the EU framework programs and in the national funding agencies pay a lot of attention to this research. And we see opportunities both for commercialization and making an impact in terms of academic research. And like I said, our core strategy is the doctor does the diagnosis and we try to help him do the diagnosis. So we are envisioning a semi-automatic process where we work with the doctor. It's not a fully automatic system. And then we give information to the doctor so the doctor can monitor the patient in a cheap way. So we don't want to waste the doctor's time. The patient can call our automated system every day and we can follow. And we are speech people, so we can do a lot of cool stuff over the telephone. So, looks like in the literature there is some work that has been done before. Most of these are not done by speech signal processing people. Mostly psychiatry or neuroscientists, they pay attention to these areas. looks like in the literature. And of course, medical doctors paid attention to it. They have found evidence, obviously, evidence in the cognitive decline in the auditory part of the brain. Okay, so that's clear. But what's more interesting is even 1 to 2 years before the doctor can do the diagnosis, actually the decline in the auditory part of the brain starts. That means early diagnosis can be done, very early diagnosis can be done by analyzing the lexicon that the person is using, the variety of the words. That's what I mean by the lexicon. Okay, and that gives us opportunities about changing the lifestyle, changing the nutrition, and doing some exercise to keep the brain more active and things like that. That's why it's important to do early diagnosis in Alzheimer's. Prosodic parameters have been found to be relevant. Prosody means pitch. How is the pitch changing? And does the person speak monotonously? Do they have any pauses and between phonations and things like that? And in this work, in our preliminary study, we looked into the prosodic parameters. That seems to be the most obvious and relevant thing we can look into. And okay, our core focus is on conversational speech. So we want to listen to people in a natural setting when they are actually talking. You know, we talk to them, we ask questions, and try to carry out a conversation with the patients. It's a natural setting. And we believe that a lot of the information, prosodic, semantic, and syntactic information is in that kind of speech, in the natural setting. The literature, okay, there is some work in spontaneous speech, but it's very few, and mostly on the semantic side of things, as far as we can see. And it's not multidisciplinary enough. That means some of the major speech labs are not involved, and mostly done by medical people. We believe that there's a lot of room for contribution if we can bring major medical people and major speech people together and do stuff together. For example, I was surprised to see that things like probabilistic factor analysis and graphical models that are some of the commonly used techniques in machine learning has not been used for this kind of study. I've seen some work on support vector machines, which is another tool that machine learning people use, but this was also done by some speech people in 2011. That's because of the recent attention that the machine learning and speech people start paying to this area. And again, this lexical deterioration analysis, I mean, the idea has been that people realize that, okay, lexicon is deteriorating. People do not use as many words as they used to. But doing speech recognition on the elderly people's speech is difficult. Making it over the telephone is even more difficult. And then making it for spontaneous natural speech, when it's syntactic, the grammar is kind of deteriorated also, makes this a really challenging task. So I think it's a major research area in itself. Even for healthy people, spontaneous speech recognition is very tough. Okay, so there's a lot of room for contribution. So let me talk about our data collection method, what we tried and how we tried to get data from the patients. Our first attempt was to set up an automated call center. The idea was, you know, we had this call center and the patients will call this PC every day. And then we had this list of standardized 20 questions that an MD actually gave us. But it looks like they forget to call. And then that is kind of, I guess, normal. And even if they call, they have a hard time answering the questions. So this strategy did not work for data collection. We had like 3 people calling us in 1 month. Okay. So we changed our strategy. What we did, our second attempt was to send a graduate student to this nursing home with a digital voice recorder. And then they started collecting data, and that's really when we started getting data. Okay. So that worked. We started to interview the patients. We ask questions, they answer, and then we try to carry out a meaningful conversation. And unfortunately, there were like only 24 patients in that nursing home, and all of them were at the latest stage of Alzheimer's. Okay, so we don't have data for different stages of the disease. These are like very late stage faults, and only 24 people. And the monitoring, the recording was just done one time only, and we believe that the information is really, if we can get data every 3 months or so we can see the progression of things. But we didn't do that here. And healthy subjects, we have 400 of them. The age range is around 30 to 50, which is also not good for testing because we are comparing with older people, so the healthy subjects should also be like in the range of maybe 60 to 70, but that wasn't the case here. Okay? Like I said, this is a preliminary study, and our experimental setup is not necessarily perfect. So we listened to those recordings. We have, I think, about 10 to 15 minutes of data from each patient, and these are interesting conversations. So we made some subjective observations to begin with. Some of the speech was slurred, meaning that we could not understand what the person was saying. Some of the words were mispronounced, some of the phonics were missing, and then a lot of the sentences were semantically or syntactically wrong. Okay? And then, so there was this interesting observation by one of the students that sometimes the patient gives a semantically good answer to the question, but if he does that, he starts repeating it himself after every 3 to 4 minutes. Okay, so that repetition pattern especially showed up when the patient gives the correct answer to the question. So that was interesting. So I think at that point the person can still think and understand what the question is and gives the answer, but then he forgets that so the memory kind of fades out every 4 minutes or so. So here are some of the parameters that we looked into. We looked into silence to speech ratio. So, okay, so KLD is a measure that we used. It's a pullback liability distance between healthy subjects and the patients. So this kind of tells us how far away the distributions are. The larger the distance, the easier it is to distinguish between those two classes. Okay, so we try to see for which features the KLD distance is high. It means they have higher discriminatory power. Okay, and we have found that silence to speech ratio had the most relevance in terms of KLD distance. I will come back to this. Silence to speech means during the conversation, what percentage of the conversation is silence, what percentage is speech, and then the ratio of those. That is silence to speech ratio. And then also speech in seconds. So we have this speech durations. The person speaks and then stops. Speaks and then stops. And then we measured in seconds how many times the speech goes on each time. And then we try to see the deviation, standard deviation between each instance. Okay. And then this max distance to median means, say, a person speaks like 50 times. We measure the duration 50 times and we find the median duration. And the max to median means what is the maximum deviation from the median duration. Okay. Again, speed and standard deviation is a related feature. So I'm not going to go over all those features, but it looks like the first 3 of them are especially relevant in this problem. Okay, and we looked into pitch, fundamental frequency. What I was expecting to see was, I was expecting the patients to talk monotonously. I wasn't expecting the pitch to change too much during the conversation. because the person doesn't really understand what she's saying. But it turned out that this is not relevant. So that was kind of surprising for me. Okay, so we have this, two most relevant features here: silence to speech ratio, and then speech distance of max to median. Okay, so these red points are the patients and the blue ones are the healthy subjects. We have a lot of healthy subjects and only like 24 patients. So what's interesting here is silence to speech ratio is pretty low for the patients. Pretty low means that there is not much silence during speech. Mostly the person talks. And what we have found out is normally healthy people, when they talk, they stop and think about what they will do next, what they will say next. But that's not the case with the patient. They just talk and then they stop. Okay, so yeah, that was, the silence to speech is very informative. And then distance of max to median is also very informative. It's fairly high for the patients. Okay, because the person either gives a short answer and stops, or he starts telling a story, and the story goes on and on and on. Okay, so that's why this max to median is can be so high for the patients. Okay. The next two most relevant features: the standard deviation of speech. The max to median was high, and standard deviation is related. Standard deviation is fairly high for the patients. Like I said, the answers can be very short or very long. The person can speak non-stop, telling a story. Okay, that's what kind of pushes up the standard deviation for the patient. And then number of silences per minute. This is interesting. This is another thing that we hypothesized, but turned out to be wrong. I was expecting the patients to stop frequently. Okay, I was like, okay, the brain is not functioning right, so the person will stammer and stop frequently during speech. But that wasn't the case. They just talk. Okay, the healthy people stop more often than the patients. The other thing that we did, KLD distance is kind of what we call the generative approach in machine learning, and the LDA is a discriminative approach. I won't go into details of that, but it's a kind of different perspective in machine learning. And we said, okay, we did KLD, we got some interesting results. Now let's see if we can discriminate between healthy people and patients. And one of the ways to do that is LDA. We measured something called equal error rate. Okay, so we look at this as a detection problem, right? So we are trying to detect if the person is ill or not. And equal error rate is, so I can tune my threshold, LDA threshold, and then we have two types of errors. There's the probability of false alarm. False alarm means the person is not sick, but we classify him as a patient, as Alzheimer's. And probability of miss means the person is ill, but I classify him as healthy. And equal error rate point is the point where probability of false alarm is equal to the probability of miss. And that's something that we commonly use in speaker verification, in our speaker verification research. Okay. So we tuned our systems so that probability of false alarm is equal to the probability of miss. And here are our equal error rates. Interestingly, here the pitch feature performed very well. In KLD it didn't, but here it did. And we hypothesized that this has to do with patients being fairly old. I think it's the comparison that we made, the biased comparison that we made with younger adults and older adults. I think that had an impact on this pitch feature. And again, standard deviation in speech and max distance to median in speech has high performance in LDA, similar to KLD. Okay, and okay, then we said, okay, we did the RDA analysis and we looked into KRD, how correlated are they? We got this equilibrium rate points and KR points, and there's kind of a negative correlation between these two, which is what we expect. It's not perfect, but I can see here when I look at this that there's a negative correlation. Meaning ER goes up when KR distance goes down, which is what we expect to see. Okay, so our result seems to be consistent in that regard. Okay, so we did this study, and it looks like from a machine learning perspective, I think these preliminary results are promising. We should continue collecting more data. We looked into each feature individually, but we could have combined them and do multivariate analysis and work on that kind of approach. We tried to fuse the classifiers, things like majority voting. We tried those, but that didn't help, and I think this has to do with the data size. If we had more data, fusing the classifiers could have helped. Another thing that we want to do is monitoring the patients over time. Not just one time, but maybe for a couple of years, we want to monitor people and see how the parameters are changing. Okay, so that's my presentation.
Okay, some questions for the speaker?
Talk about the patients have syntactical errors in their speaking. Do you feel that these syntactical errors can suppose Alzheimer problem, and you can study labeling that is syntactical errors as what is the common syntactical errors combination?
Yeah, that is actually that paper that there's this lab, very famous lab in speech recognition at Portland, and they came up with a paper in 2011, and that's exactly what they were looking into. Yeah, so this is Turkish, of course, so we have to look into this.
The problem is that probably is dependent on the on the culture.
Yes,
the language.
Yes, but they did find patterns.
Yeah, it's good interesting,
but they are confusing. Confusing nouns with adjectives and things like that. Changing the order of things.
Interesting to know if there is a relation among the different languages and what are the syntactical errors.
That's also
to detect some change in the language that are equal in all languages.
Yeah. So some universal patterns that person every language. Yeah, I think that would be very interesting to do. I think we should do this.
More questions? Have you labeled your data with more labels than healthy or versus patient? For example, I don't know, the mood of the person in that moment, the emotions, or maybe also the sex, the age, or the social condition. Because then, if so, have you analyzed the relevance of those factors in the separation of these parameters?
Actually, this is another important point. We at least wanted to do the gender thing. You know, we have to separate males from females and look into that, but there wasn't enough data to do that. I think we should do that too. We have more data.
Any questions for the speaker? Okay, thank you very much for coming to this session. I think there were different talks and very interesting. I think it's all of them have in common that the cognitive and emotional interfaces of the computers and the persons are now really relevant for our ICT research. So thank you very much, and we can continue.